Started. So hi, everybody. We're really happy that you're going to be finishing up your conference with us. Today, we're going to be talking about using efficiency to up your clinical game. We hope over the next 20 minutes, you'll be invigorated to explore the topic further. I'm Eric Blazer. I'm the clerkship director at Inspire Medical Center in Vineland, New Jersey. And the two other speakers with me today are going to introduce themselves.
My name is Kimberly Schertzer. I'm the Director of Emergency Medicine Simulation at Stanford, and I run our Stanford Simulation Fellowship.
Hi, I'm Guy Carmelli. I'm an assistant professor at UMass in Worcester, Massachusetts.
All right. So we have no conflicts of interest, and our goals for today are really, we're going to try and define efficiency as it pertains to emergency medicine. Understand the very roundabout way that we measure efficiency. Then we'll analyze the available data and select recurrent themes that show up in that literature. And then finally, we're going to demonstrate that efficiency is a teachable skill and discuss our newly developed efficiency curriculum. So Merriam-Webster defines efficiency as the quality or degree of being efficient. And since we aren't really supposed to be using a word in its own definition, efficiency or being efficient is defined as productive of the desired effects, but also capable of producing desired results. And then the key is with little or no waste. And that's really the key. So EM efficiency doesn't really have a true definition in the literature. It's very subjective. However, from our research, there are three different arenas in which we really can be efficient. So the first is provider efficiency, and this is individual efficiency on shift, your individual efficiency as to not waste the time of the provider. Then there's patient efficiency, which is, the individual patient care, how time wasting relates to the patient. And then departmental efficiency, which is the movement, the use of staff, the space, ancillary services. So all three of these are interwoven in ED processes and each require a different skill sets that are required to master patient efficiency, like communication and empathy, don't necessarily translate to departmental efficiency like time management. So it's more complicated than just like making a list and committing it to memory. So before we dive into the literature on how to be efficient, I think it's important to understand why we should be efficient. So I think we can all reflect back to a recent ED shift that went smoothly and another that didn't. And I think that when you think of why it went smoothly, it's because of a lot of efficiencies on shift, right? You got your CAT scan read back really quickly. The patient went up to the floor really quickly. You seamlessly managed the waiting room full of 6 when you got there, that was 0 by hour 2. And shifts that aren't efficient, kind of the exact opposite. I also have had shifts where I've had a patient die in the waiting room, or we haven't had space for a really sick EMS patient. And it always has left me wondering, if I was faster, if I was more efficient, would I have gotten to that patient sooner? Would I have had a place to place that patient not in the hallway? And then of course, in one way or another, income efficiency is tied to our income. Either it's a percentage of your hourly or your bonus. It's, we measure these proxy measures, but as physicians, and as teachers, we're charged with teaching emergency medicine and preparing our learners for a career in emergency medicine. And as this is such an important part of our career, earning money, I would charge that efficiency would fall into that category. So how do we measure efficiency? The short answer is we don't. We have many metrics that infer efficiency and that efficiency is related to, but none are direct measures of efficiency. We have individual metrics, departmental metrics, such as RVUs per hour, door to doc, doc to dispo, admission rate. It's an LWTs, but none of these are actually measuring efficiency. They're not directly measuring efficiency. So now that I've convinced you that efficiency is in fact important, and just by being at this lecture, I think you've decided that for yourselves. So how do we teach it? And how do we learn efficiency? Well, it seems like it's not so formal. We use advice, we allow residents and others to observe us and what we individually perceive as efficient practices. And maybe someone gives the occasional lecture and there's the occasional expert advice article that comes out. But mostly it's through our own ED experience, limited to the EDs we work in which we gain those skills. But how do we take our efficiency skills that we learn at our hospital and extrapolate it out to other places to being efficient? There was a recent publication by my co-speaker, Dr. Carmelli, and it was in AEM Education and Training, just published in 2021. And many programs found that efficiency is important. They all said that efficiency was really important, but there was no standardized way to teach it. And this topic becomes so important as we as physicians are asked to do more with less, and as burnout rates are rising. So now we're going to dive into the literature as I pass it over to Dr. Schertzer.
Thank you. So we wanted to look at this systematically. We started our journey into efficiency by questioning whether there was a need for the work in the field. And note that this was done before Dr. Carmelli's publication that Dr. Blazer just mentioned. We set out to do a needs assessment at our respective residency programs and found that efficiency was felt to be important, hard to define, and in general, poorly taught. We then embarked on the next two steps, a literature search and a thematic analysis. We began by looking at the traditional literature using PubMed and Ovid as the usual search methods that we all employ when we're studying a problem. And this search revealed actually only a few useful articles. We suspected that there was more out there, however, so we turned to the non-traditional literature, including blog posts, websites, and more of the light EM sources. This yielded a few more mentions of efficiency, and combined, we found a total of 54 sources that mentioned or dealt with efficiency in emergency medicine. We tabulated findings from all of these articles and other non-traditional sources, and the resulting table looked a bit like this. Some literature talked about tech fixes. These included EMR tips and tricks. It addressed the development of shared resources to provide systems tips to colleagues in order to help them navigate things more efficiently. Other literature looked at low-tech assists. These were the helpful hints like chart on shift or be decisive. We can argue about their usefulness, but at least they committed to a tip. The remainder talked about efficiency, but they really provided no useful or actionable steps. Each of 4 independent reviewers then went through that table, classifying each efficiency point from the table into themes. And we found that they fell into 3 thematic categories. Theme 1 was the order of operations. Included in this theme was focusing on disposition early, meaning resuscitating first, discharging second, and seeing new patients third. It also included task prioritization and batching of patients by geographical locations as distinct, discrete tools. Theme 2 was anticipating roadblocks. This looked at the things that bog us down and result in unnecessary delays, things like patients not being in gowns or rooming patients who need pelvic exams in the hallways. It also looked at ways to offload tasks to other team members, and it encouraged overtly seeking the agenda to prevent the oh, by the ways that derail us when we think we have an easy, efficient discharge. Theme 3 looked at communication, and this meant verbalizing the plan to both the care team and to the patient as means of setting expectations. It also included using things like closed loop communication to prevent the inefficiencies that come with errors.
All right, so now that we've excited you so much on the topic of efficiency, I know you're all clamoring to find out, so how can I go off and teach efficiency to my learners, right? Well, that's where I come in. Let's talk methods. So there aren't a lot of papers on teaching efficiency. However, this doesn't mean teaching efficiency cannot occur. In fact, there are a couple studies that look at resource utilization and efficiency, and they show that you can reduce a provider's resource utilization and improve their efficiency merely by providing them with feedback on practices relative to the peers. This suggests that providers are willing to change and improve in their practice if given the right information and specific guidance on how to do so. There's also a study by Venepal et al. That showed that you can teach efficiency using a workshop, and I'm going to talk about that in a few slides from now. So let's go into some specific examples of how to teach efficiency. I'm going to start with the most time and faculty intensive, and then progress to the least time and faculty intensive. All right, so in the first category, I call data, then feedback. Here, in order to teach efficiency, you will begin by gathering as much data specific on a learner's either efficiency or inefficiencies, and then give specific feedback to them on how they can improve. So let's begin with how to gather your data. The field of ethnography is one in science of observing cultures and customs of individual people. In science, there are studies referred to as time motion studies, where providers are observed and their motions and amount of time spent on certain actions are recorded. There are various ways to perform a time motion study in order to gain rich amount of information, in our case, data specific to efficiency. First, we have the direct observation. Here, a researcher or educator directly observes a provider, often through on-shift shadowing. This can be done in person or even virtually using cameras. This could occur continuously over the course of an entire shift or a given amount of time, or it could occur as a work sampling where data is gathered at preset intervals like every 5 minutes or every hour on the hour, or during certain situations like whenever the learner is doing a procedure, for instance. This allows a researcher to bounce between various participants. Then we have the self-reported option, allowing participants to report their own activities. This can be done synchronously throughout the shift or during set intervals, like if there was a reminder timer that went off and had you put in your actions, or asynchronously, let's say at the end of a shift. And then finally, you can perform a technology assisted. So with all this advent in technology, we have Apple Watches, Fitbits. You can automatically, using these devices, monitor activity. So they can track positioning and movement. There are accelerometers and step counters and cameras and various sensors that can monitor movement and action. Now we have in our data gathering efficiency metrics. And I know Dr. Blazer talked a lot about this. So there are certain things that you can gather straight from your electronic health record or EHR. You can track productivity through RVUs or patients per hour. You can look at acuity level by looking at ESI levels or admission rates or critical care time. There are also specific metrics such regarding ordering, such as time to first order or how you order, if you batch orders or if you do orders in sequence. And then finally, time spent documenting can also be a surrogate to efficiency. If you're spending a lot of hours documenting during your shift or staying late after your shift or turning in documentation days or weeks later. Now comes the feedback portion after you've gathered the specific information. This is optimally done during one-on-one feedback sessions, either right after a shift or like at certain periods throughout the year. And then you cite specific examples from the data you gathered. Some programs provide context for their efficiency metrics by releasing data of other residents in an unidentified or de-identified manner. Some might even release a class rank to say you are at this level relative to your peers or at rank whatever. Workshops can be made to teach efficiency. One study that was done was an interactive workshop to discuss time management and patient-physician flow in order to improve efficiency and productivity. And then the study I mentioned before by Venepal et al. Looked at 4-station workshop to kind of look to see if we can improve in efficiency. The 4 stations that they did was acute care, minor care, charting, and communication and sign out. In this study, there was a positive self-perceived improvement in efficiency by the participants, making teaching efficiency with workshops promising. Simulation is all the rage of late, and you can teach a variety of topics. Here's one study where they sought to evaluate task switching as a surrogate for efficiency. So basically they had the learners do one simulation, and then mid-simulation, the student was handed an EKG of a STEMI, and they needed to task switch, like finish up here and go to the new STEMI, and they were monitoring their ability to do that. So this kind of gives promise to being able to use simulation for efficiency. There's even a board game called Gridlock that was created to teach patient flow as a surrogate for efficiency. Here's a paper showing that the game can be useful to teach some of these concepts. Small group exercises or flipped classroom discussions would be an excellent way to discuss or brainstorm improvements in efficiency. One study employed a think aloud exercise of simulated multi-patient scenarios, which helped learners create their own conceptual framework to dealing with busy ED situations. And then now we're at the low end of the time/faculty intensive spectrum, and we get to didactics. It's just one faculty member to a large group of learners. You could teach general efficiency topics that we kind of discussed about earlier. You can record it and give it again and disseminate it and whatnot. And then finally, take away even the faculty lecture, and you can just have the learners at home doing a curriculum asynchronously using a virtual learning platform to teach efficiency. And that's where I want to introduce the curriculum that Dr. Blazer and Dr. Schertzer and I put together. It's using 3 categories as 3 different modules: order of operations, rate limiting step, and communication. Those are what we identified from the literature. And to our knowledge, this is the first efficiency curriculum that's been placed as a virtual learning module of its kind. Let me show you a little snippet of it. So here it starts off with different videos. It has learning objectives. You can enter different scenarios, like, you know, a track board, and here's the patients. There's always questions to do knowledge checks, and it follows different stories of patient encounters and communication, and ask you what you'd like to do next, and you kind of get to pick out the order. Some of it has videos of good and bad scenarios for communication, along with asking questions about what was done well versus what was done poorly. So that's kind of how it looks. We are planning to pilot this curriculum this summer locally at our institution, but plan to eventually disseminate it globally for free open access on the web. So stay tuned and feel free to reach out to us for more questions on how we put it together. And then hopefully we can get your learners to use this curriculum as well to just improve an overall efficiency in the future.
So we would like to take a moment to thank you all for your time today. And to wrap up, we talked about many ways to measure efficiency, which may be different at different institutions. We said there was little in the formal literature, some in the non-traditional literature, and even less on how to effectively teach it. And finally, we said that key efficiency teaching methods include time motion studies and directed feedback, simulation, gamification, workshops, and virtual platforms. And with that, I'd like to open it up to questions.
So Sierra, you've played the Gridlock game? I haven't gotten my hands on the actual board game, but it seems really fun.
Yeah, I actually have it. I used it, excuse me, for our EMIG. We did a game night. And so I have that game. And then we bought, there's an antibiotics game. I'm blanking on the name of it, but it's like a pediatrics antibiotics card game. And we played that too as a game night thing.
Wow. Okay, we have a question. How do you make sure that attempts to improve efficiency don't cause providers to feel pressured to cut short patient encounters? Kim, do you want to talk about that?
Sure. So I think the key is to find opportunities to trim time in the non-patient, like actual patient care environment. So, so you can maximize your time with your patients, but you minimize your time walking between rooms that are geographically spread apart. That way you're more efficient. You've shaved off a few minutes in the travel time, but you haven't done that at the cost of the time spent with the actual patient.
And there was one of the papers that I really liked that looked at how physicians, residents, and nurses spend time. And it saw that it's like 40% patient care, it's like another 40% indirect patient care, and it's another 20% of non-patient care. And a lot of the instructions for efficiency aren't trying to minimize the patient care aspects, but trying to minimize those non-patient care, like doing all the unnecessary stuff, extra stuff that wastes your time. So yeah, it's not the goal of efficiency practice to reduce the sitting at the bedside time. It's trying to reduce the other stuff to allow you to have more of that at the bedside time. And then I saw a question.
Yeah, there's another question in the chat. In our search for efficiency, did we come across any books that would be helpful? I don't remember seeing any books. I don't know if either of you do. There were a couple really good, like basically like blog post FOMED articles that we tied in a lot. I think there's a lot written on efficiency in business, and I think there is some translation between the two, but I don't recall ever seeing one related to specifically medicine or EM.
Yeah, when we were doing our PubMed search, it wasn't really textbook related, but that's a good point. And if this curriculum is a success, we'll write a tell-all book on on it. Oh, great. And Kim has some ideas as well. That sounds great. See, PGY1, you're the person we're trying to target for this curriculum. So hopefully we can get it out to you and like your colleagues so that all these lessons could be taught. Now you just got to give that uncomfortable silence for like 2 minutes to allow people to ask all their questions. All right. Well, I think that's 2 minutes, right?
Yeah.
Yeah.
That's
all right, I'll put my email as well.
Yeah. Thanks, everybody.
And we're done.